Welcome to the GUJ DIGI NEOCON. This is the Gujarat State chapter of NNF. This is a state conference of neonatology. We are having, tomorrow is the main conference and today is the pre-conference workshop. Golden hour management by simulation was one of the most sought after workshops, and after 80 we had to close down this particular workshop registration because we had to move and it would have become difficult, and it was one of the early workshops to get filled. And I'm sure the esteemed faculties over here, myself included, will do a fantastic job and we'll have a lot of fun learning, relearning. This is going to be simulation, so it is not going to be didactic at all. We will have to interact, and majority of our, almost all of our faculties are well versed with simulation training, simulation teaching. At the outset, let me thank Mr. Bashir Bhai. He is our technology consultant and they have done a wonderful job. And these breakout rooms and all, these are difficult things for us, but he made it very easy. Let me first introduce the faculty and then I welcome Dr. Vijayanand Jamalpuri. He is the course director or the national coordinator of this workshop. All his degrees are from foreign. If you look, all of our majority of our trainers today have degrees from outside. So he's done MRC PCH, FRC PCH. He's done fellowships in neonatology. If you look at his PPT slide, he's got training. He likes to teach, and he is the president of PEDISTARS. PEDISTARS is, for people who do not know, Pediatric Simulation Training and Research Society of India. They are the main people who do simulation work, and for India, he is the president, and they do fantastic job all over. He is also a consultant neonatologist and pediatrician at Rainbow Children's Hospital, and the entire plan is being designed by him. Next is Dr. Amit Chitalia. He is from Ahmedabad, from Gujarat itself. He is the director of PICU at the prestigious SIMS Hospital, Ahmedabad. Even he's got, if you look at his degrees on the right hand side in red, Berlin, France. He's done significant work in fiber optic bronchoscopy and ECMO, one of the pioneers of ECMO in Gujarat. Next is Dr. Anuj Grover. After doing pediatrics from Ahmedabad Civil, he's worked as 12 years at UK in a tertiary care NICU. And then he runs a 50-bedded NICU. Imagine 50 beds of only an NICU. Otherwise, he is also a core faculty for NEST, which is another simulation training course, NeoSim, PEDISTARS. So again, a very experienced person in neonatology and in training in simulation. Then we've got Jaisal Seth. My connection with her goes back to Wadia when she was my super senior. She's done, again, she's also been at Sick Kids Toronto. She's done PICU fellowship, also done NICU from Sick Kids Toronto. She's got a lot of things written, but one thing which she has missed out, which I would like to bring out, is she is regularly on the cover of a lot of magazines as top 10 pediatricians of India, top 15 of Mumbai. Also, she recently received an award from the governor of Maharashtra. So that is Dr. Jaisal Seth for you. Then we've got Dr. Ranjit Gowda. Again, he's done his training in the UK and he Again, his core interest is simulation training. He is a consultant neonatologist at Butterfly Hospital at Hyderabad. This is myself. I am a pediatric intensivist from Wadia and then fellowship in neonatology from Manipal Hospital. Right now I'm at Amruta Hospital, Surat. My interests are electrolyte disturbances and ventilation. Then there is Dr. Amit Dahat, who has done his training in India and in Singapore. His interest is in echocardiography. He's also done an MBA in management, and he is the director of a very big unit at Nagpur. Again, a lot of trainers, faculty for a lot of training in India. Next is Dr. Lakshmi. She is also a consultant neonatologist at Hyderabad. Dr. Lakshmi, could you please introduce yourself? Dr. Lakshmi? Is Dr. Lakshmi there?
Ranjita Vijay can do.
Dr. Ranjit, can you introduce Dr. Lakshmi?
I can.
Hello.
Okay.
Good evening, Dr. Snehal.
Yeah, hi, good evening.
Good evening, everyone. I'm sorry about not sending my introduction PPT. I'm Dr. Lakshmi Vedprakash. I'm a consultant neonatologist and pediatrician at Birthright by Rainbow at Kondapur, Hyderabad. I did my MD Pediatrics and MRCPCH and from UK. I'm currently working as consultant in Rainbow Children's Hospital.
Yeah, thank you very much, Dr. Lakshmi.
Lakshmi also trained from PDStar for the faculty, and she has interest in simulation as well.
Yeah, can I hand over to Dr. Vijay sir?
Yeah.
You will take over, give us the rules, regulations, what is to be done, what is not to be done. Over to you.
So please once again inform to all the delegates to change the name for group wise.
Yeah, I'll just quickly go through this and right away before you start, Vijay sir.
Yeah, go ahead.
Bhumi Patel, Dr. Dr. Shreyas, Dr. Sai Kanan, Dr. Majority have done. Dr. Harshad Takwane, Dr. Khush Junjunwala, Dr. Monish Shah sir, Dr. Pujan Patel. Yes. रंजित, अरे बशीर भाई, अगर नहीं होता है तो बाद में डिस्ट्रीब्यूट कर दीजिए.
हाँ, ओके सर. हॉल मतलब ग्रुप ए में कम लोग हैं उसके लिए.
हाँ.
Okay. Snehal, shall we go ahead?
Yes, please go ahead, sir.
Yeah. So very good evening to all of you, and so thank you for Gujarat NNF for giving us this opportunity. And on behalf of all the faculty, we have excellent faculty this evening, as Snehal said. And so, well, what I want to tell first is the program of the day. It's like a 4 hours workshop, and then we have a series. We have a series of 3 lectures, short lectures, or one about golden hour management for preterm by Ranjit, and then next golden hour management in term, that's by Dr. Jaisal. Wow, we didn't like the topics each other, so we exchanged between us. So, and then after that, what will happen then? NRP 2020, because as you know, there's a revision of the NRP every 5 years, which happened. And then what will happen is we will divide virtually all of us into 4 groups. So as Snehal already explained, and then the faculty will be keep changing every 35 to 45 minutes between, and we'll be discussing one scenario by showing the video clip to you. That means in that we can discuss that when we go to the individual groups, briefly, what we'll show you, we show you the clinical scenario. For example, I'll show you here. Yeah. So transport of preterm baby from delivery room to NICU, or in general about the preterm transport. We show you a video, and then we ask you to observe that particular video and apprise it, writing down what went well, both the clinical care and also human factors. So then we sit around virtually and chat about the case and try to learn something out of that simulation exercise of somebody else done. Now, similarly, you don't have to change. We will be changing to the breakout rooms each in the pair of 2. And then in the end, we'll group come to the same hall virtually, like we are all in now, and have a quick question and answer if you want on the chat box, and then we move on. So if anybody, then before we start the lectures, and I want to say there are certain rules on virtual platform. You can raise the hand if you want. We'll keep checking in the groups, and especially it can be difficult when we are on the screen sharing. But one of the faculty will be keep checking if anybody raise the hand, and use the chat box wherever possible, and mute yourself when you are not talking. And if somebody is talking, please be patient and wait until that particular person is finished. And we would like you to open keep the videos on, especially during the interactive sessions of the breakout rooms. So I'm going to stop it there. I'll stop sharing the screen. And it's Ranjit is the first you are going, is that right? Let me check any question in the chat box. Anybody has any questions, you can put so in the chat box. I'm just seeing. Okay, fine. And the key important thing is, as Snehal earlier said, it has to be a interactive session. So I mean, interactive. I know in a physical form we would talk to each other, seeing each other. In virtual form, it can be difficult, but it is doable, and you can interact by chatting as well in the box. So, and when we go into the breakout room, we want to be very attentive and watch those videos and pick up what are the things went well, what could be improved, and why went well, why we need to improve on. Okay. I think Ranjit wants to play a game before we go on. Can I have all the participants have a A4 sheet open, please? And I want your videos on, please, if you don't mind. I want your videos on. When we say game, we mean game. So we're going to play a little game. My dear faculty, you all have white paper? Okay, yes, Nehal, good boy. Yeah, okay. I do have one, and I'm going to sip a tea in between.
Can we wait for a few seconds to keep all the videos open?
Yes. I'm waiting. I'm not doing anything yet.
Yes, and since, dear delegates, since this is a workshop, all the videos, as Dr. Jaisal has said in the chat box, will be open for all times.
Yeah.
किसी को OPD करना है Saturday को, तो it is not allowed. Saturday evening OPD आज cancel कर दो.
But you are allowed to have tea, coffee. Ask somebody to get a cup of tea and coffee.
ओपीडी रीस्केड्यूल करो, 8 बजे के बाद करते हैं. हम सब ने वैसा किया.
हम कर लिए ऑलरेडी.
नहीं, GUJ has to do OPD, but after 8 we can't cancel.
Yeah. And the reason why I'm emphasizing coffee and tea and water is, I strongly believe physical and physiological needs comes before educational needs in the Maslow's hierarchy. Yeah. So and GUJs are very good looking after it. I have experienced that from Motabhai, Dr. Amit, and Anuj when I visited Ahmedabad. Of course, Nehal, when I visited you, of course, Jaisal, and you are very good at it. All GUJs are very good in hospitality. Well, they are not good at what? In everything, basically. ठीक है, चलो शुरू करें. Okay, right. So you close your eyes, all of you, Okay, I'm going to give instruction. Please follow them as I say. Fold the A4 sheet your hand into two halves. Okay, and again into two halves, and tear off the right upper corner, and fold again into two halves, and tear off the left upper corner, okay, and fold into two again, and tear in the left upper corner again. Okay, done. Okay, now open your eyes and keep your videos on. Show how you got your. Okay, look at that. Same.
And woman sexual dysfunction, not given much importance, but now patients are coming forward and getting treated. Risk factors are like angina or myocardial infarction, like cardiovascular diseases, diabetes mellitus, hyperlipidemia. Earlier, alternate diabetics used to have this erectile dysfunction, minor or major. Now, nearly 75% of diabetic patients are coming having the mild or moderate or severe erectile dysfunction today. Etiology, again, the multifactorial, organic, hormonal, anatomical, drugs. There are many drugs for psychiatric problems and hypertension. These are having some effect on causing erectile dysfunction. Psychogenic, already I mentioned, 10% of the cases psychogenic, pure. The organic causes, it may be vascular, CVD, atherosclerosis, hypertension, hyperlipidemia, and smoking. Central causes includes Parkinsonism, stroke, or multiple sclerosis, tumors, spinal disease, or injury. Peripheral causes, peripheral neuropathy, diabetes, alcoholism, uremia, and pelvic surgery. Any pelvic surgery, pelvic radiation leads to nerve damage, leading to erectile dysfunction. Alcoholism, liver metabolism is altered, so testosterone metabolism, so it leads to erectile dysfunction. Diabetics, multifactorial, neuropathy, sugar, more sugars, and arterial involvement. Everything does multifactorial leads to the most common cause nowadays. Hormonal cause, not much common, rare actually, but we can see these secondary sexual characters, much other things, or some thyroid or hyperprolactinemia or Cushing disease, hypogonadism, secondary sexual characters absent. Even after 40-50 years, we have to see the size of the prostate. Size of the prostate is a good clue that patient androgenically is good, because it shows depends on the prostate growth, depends on the testosterone levels. So these are the good signs of 40-50. We are also to know the testosterone level. Peyronie's disease, this is a nasty disease, more than 300 years, no correct treatment. There is will have plaque in the corpora, and corpora cavernosa becomes fibrotic. It won't expand. It causes pain on erection and curvature. The Peyronie's disease, this leads to problem. Micropenis, anomalies, maybe hypospadias, epispadias, any lesions, performance failure. This is very important because today nowadays, we're actually using number of medicine. Beta blockers, tricyclic SRIs, phenothiazines, phenantine, carbamazepine, antihistaminics, is ulcer drugs, cementidine and ranitidine, recreational drugs like tobacco, alcohol, marijuana, other drugs. These have to change according to, suppose cardiac drugs, you have to consult with the cardiologist, you have to change the drugs, it's not having any effect on the brain or blood pressure or locally. Psychogenic, already mentioned, it requires psychologist evaluation, result of intimacy, lack of arousability, situational, partner change, it improves, depends on the partner. Performance anxiety, psychiatric illness, anxiety state, depression state, psychosis, alcoholism. All lead to different levels of erectile dysfunction. History is very important, it gives a good clue. Mostly the two entities. One is organic erectile dysfunction or psychological erectile dysfunction. This detailed history is very important. Cardiac gradual onset. Suppose patient getting 6 months, it is organic. Patient having within after some upset in the house, or it's only 1 week or 10 days, 15 days, is psychological, maybe. Normal ejaculation, that shows psychogenic. Normal libido. Medical risk factors include trauma, surgery, and other pelvis. Current radiation or modification of things. Lifestyle is also very important. Smoking, drinking, no obesity, not having proper physical exercise to the body, all leads to organic. This history suggesting psychogenic is very important. Even history you can get. They will say every male patient, they will have 3 types of erections. One is central, second one is contact, local. Third one is REM sleep phase. You'll getting nocturnal erections. Every male will have every night 3 to 4 erections in REM sleep period. But we can evaluate. Even patient will say, sir, I have early morning erections, otherwise I'm not able to perform. Early morning erection is very important. Say it is a psychological. Okay. Number 2, we can assess. Simple methods are available. How to assess? We have sleep labs. We have Regiscan to record this. And then sometimes we can have even postal stamps strip. We can attach to the penis. It broken in the night means it was enlarged. Night enlarged, how much enlarged? There are different methods to diagnose. Nocturnal erections. Nocturnal erection is a sign of psychogenic disease. Sudden onset is psychogenic, early collapse of erection. Self-stimulated waking erections, premature ejaculation, major life event, psychological problems. Examination, after detailed history, exam is very important. Genitourinary examination is anatomical abnormality, size of the testis, to hormone levels, testosterone. Pulse, is there any pulse difference? That will help decrease blood flow to that area. Coarctation, aorta. Rectal examination over 50 is very important. Gives how the androgenic status of the male. Very important. Investigations, you can do battery of tests. That's one approach. But now